right, let's go ahead and get started. All right, so it should be a fairly short lecture today, actually, because we're just going to cover the structures in the posterior abdominal wall, much of which you've already dissected last time. Should be a relatively quick lab, too, because I think the only thing you have left to do is to look at the nerves, the branches of the lumbosacral plexus, the nerves in the posterior abdominal wall. Plus, additional time if you just want to review things for Monday's exam. So, as you recall, we removed the contents of the abdomen on Tuesday, and all of the digestive organs, and exposed the structures in the posterior abdominal wall. So these are all primary retroperitoneal structures. So remember what that means is that these are all structures that in the embryo developed posterior to the peritoneal cavities. They were never hanging or suspended within the peritoneal cavity like the intestines are. They've always been outside of the peritoneum. So first of all, we've got some major blood vessels back here. So the aorta. The aorta obviously is coming down through the thorax, where we call it either the thoracic aorta or the descending aorta. It's going to pass through a little opening in the diaphragm and then enter into the abdomen. And at this point, we would refer to it as the abdominal aorta. The aorta then continues down, and right around the level of about L4 or L5 vertebra, the aorta ends and bifurcates into a pair of iliac vessels. And I guess I should probably come in here sometime and update this. Technically, these would be called common iliac arteries, right where they first split. And then each common iliac artery splits again. And you see there's another split over here. The common iliac artery splits into an external iliac, which is eventually going to run down into the thigh, and then an internal iliac artery that's going to continue into or remain mostly inside the pelvic cavity and supply structures inside the pelvis. We'll come back and talk more about those in a lot more detail when we actually start studying the pelvis, which will be right after the next exam. The aorta gives off a whole lot of branches here in the abdomen. There are the three branches that come off the anterior surface of the aorta. So that would include celiac trunk. And hopefully when you removed your abdominal organs, you left a little identifiable stump of the celiac trunk. Then the superior mesenteric artery would be branching off next from the front of the aorta. And then finally, inferior mesenteric artery. None of these are actually labeled on this slide, but there's the inferior mesenteric artery sitting quite a bit lower, just a little bit above the bifurcation of the aorta. Then in addition to those unpaired arteries that branch right off of the front of the aorta, we also have a lot of paired arteries. So in other words, arteries that have both a left and right. We've got the renal arteries supplying blood to the two kidneys. If you ever have to illustrate the kidneys and their relationship to their blood supply, make sure you show the left renal artery being quite a bit shorter, the right renal artery being quite a bit longer, simply because the aorta is shifted a little bit towards the left side of the body, so it just has farther to travel to reach the right kidney. The gonadal arteries both branch off of the aorta. Now, the term gonadal is a generic term that refers to either the testicular arteries in the male or the ovarian arteries in the female. If I tag one of these on exam, I'd prefer that you peek down and try to determine the gender of the cadaver and answer either testicular or ovarian, and then I'd rather you didn't use the generic term gonadal.
Is there a significant difference in structure that necessitates the different name, or is it just
no, just because one's going to the testes and one's going to the ovary. In terms of where they originate off of the aorta, there's absolutely no difference. The only other difference would be the fact that since the testes descend into the scrotum, the testicular artery actually has to travel through the inguinal canal as part of the spermatic cord. But at this point in the abdomen, there is no difference at all between ovarian or testicular arteries. Okay, so then we have some veins which are more or less identical to the pattern of the arteries. So we have iliac veins, and there's again an external iliac vein, which is a continuation of the femoral vein coming up out of the thigh, and an internal iliac vein bringing blood back from structures in the pelvis. They join together to form two common iliac veins, and then the two common iliac veins join together right about the same level, right around L4 or L5 vertebral level, to form the inferior vena cava. And the inferior vena cava is then going to travel up to the diaphragm and pass through a separate orifice through the diaphragm. So we'll look at the diaphragm in more detail in just a minute, but there are three different orifices or hiatuses. I don't know if that's the plural, hiati, I don't know. I'm not sure what the plural of hiatus is, but there are three separate openings through the diaphragm for the esophagus, the aorta, and the inferior vena cava. So inferior vena cava is going to pass through the diaphragm directly into the right atrium of the heart. Some of the other veins that are flowing into the inferior vena cava include, see these three little cut holes here, way up near the top of the inferior vena cava, just before it passes through the diaphragm. Those are the hepatic veins. So we talked about how there's a hepatic portal vein that brings blood from the digestive organs into the liver. That blood then has to be filtered at the cellular level, through the liver. And then those veins then join back together again to form a group of hepatic veins that then drain into the inferior vena cava. There are actually three of them. Those are the three hepatic veins bringing that blood from the liver back into the inferior vena cava. We've got, of course, a couple of renal veins, and the length of the renal veins is opposite the length of the renal arteries. So in the case of the veins, because the inferior vena cava is shifted towards the right side of the body, that means that the left renal vein has to be longer to cross over the midline to reach the left kidney. The right renal vein is a little bit shorter. There's also a difference in the gonadal veins. So again, either testicular or ovarian veins. On the right-hand side, the gonadal vein drains directly into the inferior vena cava. But on the left side of the body, the gonadal vein is actually going to flow up and flow into the left renal vein. And then, so in other words, sort of flowing indirectly into the inferior vena cava by way of the left renal vein. Some of the other structures back here, of course, we've got the kidneys, which you looked at in lab on Tuesday. The kidneys are a little bit different from one another. They're roughly the same size and shape, but oftentimes the left kidney is a teeny bit bigger than the right one, simply because a lot of room on the right side of the body is occupied by the liver, so there's just a little bit less room for the right kidney. The right kidney almost always sits a little bit lower in the body, so that's another thing to make note of if you happen to be illustrating the urinary system and you're showing the kidneys, either showing the kidneys in the abdominal cavity or even just showing the whole urinary system sort of outside of the body. Just make sure you show that right kidney is sitting a little bit lower than the left one. That's again because of the presence of the liver over here on the right side. We'll talk more about the kidneys in detail in just a minute. The kidneys, of course, their main function is to produce urine, but through the process of producing urine and through the selective reabsorption of different ions, the kidneys regulate the balance of different ions in the body, things like bicarbonate ion, sodium and chloride ions. And the kidneys also play a very significant role in helping to regulate blood pressure by how much fluid they eliminate or how much fluid they reabsorb, how much water they reabsorb. If you're very dehydrated, the kidneys are supposed to do a really good job of reabsorbing a lot of water out of the urine so that you produce a very dark, very concentrated urine if you're dehydrated, because the body is reabsorbing a lot of the actual H2O from the urine, trying to preserve water. On the other hand, if you have if you have high blood pressure, one of the common treatments for that is to give people diuretics, which is a type of drug that just increases urine output as a way of getting rid of excess liquid to lower the blood volume and lower the overall blood pressure. A lot of older people will say, oh, I got to take my water pills, meaning they're taking a diuretic that just makes them pee a lot to try to help control their blood pressure. Sitting on top of both kidneys, we have a pair of adrenal glands. And this may be a little difficult to see in the cadaver. I know some people were struggling even to find the adrenal glands just because they look an awful lot like the fat. And so it's very easy to just remove all the fat from around the kidneys and just destroy your adrenals. I think most people did actually end up finding them, but there is actually a noticeable difference in shape. If you can really find them very clearly, especially like an unpreserved cadaver, or if you could actually see them in the living person somehow, the left one has a little bit more of a rounded look to it, and the one on the right has much more of a triangular shape to it. I like to think of the adrenals as being like little hats on the kidneys, and I think of the left one as being like a beret that's kind of flopping on somebody's head, whereas the one on the right is like those little triangular paper hat, like the little pirate hats that kids would make out of just folding up a piece of paper. Anyway, or maybe a little pointy elf hat. How about that? Yeah, yeah. The adrenals have their own blood supply. Some of that is branching directly off the aorta, as well as veins flowing back directly into inferior vena cava. But many of the vessels that are supplying the adrenals are branches of the renal artery and vein. Coming out of the kidneys, you have the ureters, which are bringing urine from the kidneys down to the urinary bladder. They're going to cross over a muscle here. The ureters will then cross over the iliac artery and vein, and then continue down into the pelvic cavity where they flow into the urinary bladder. A little bit of a close-up here of some of these structures, and you can again see the kidneys where they're renal arteries and veins. The left renal artery being shorter than the right renal artery because of the location of the aorta. Then the opposite being true with the veins. The left renal vein a little bit longer, right renal vein a little bit shorter because of the position of the inferior vena cava. Again, you see those gonadal vessels, again, either ovarian or testicular, where both gonadal arteries branch directly off the aorta. The right gonadal vein flows into the inferior vena cava, whereas the left gonadal vein flows up into the left renal vein, and then that blood would then cross over to the right to get into the inferior vena cava. And you see that distinctive shape of the two adrenal glands, the little bit more rounded, sort of droopy look to the one on the left, and then the triangular shape of the adrenal gland on the right. So talking a little bit more about the structure of the kidney itself, you sliced into the kidney in lab on Tuesday. You basically sliced it in half and kind of folded it open like opening up the pages of a book. And I know sometimes these structures are not real clear in the kidneys, but hopefully you're able to make out some of these structures. First of all, there are two distinct layers to the kidney. There's an outer layer called the cortex, which really doesn't appear to have a whole lot of structure to it, just a little bit of a rough sort of grainy texture to it. And then the deeper layer of kidney is called the medulla. This is usually a thicker layer. And in the medulla, you have these structures called renal pyramids. The cortex and the medulla both contain nephrons. So on a microscopic level, there's not really a whole lot of difference between the cortex and medulla, although the nephrons in those two areas have somewhat different shapes to them. But both regions are basically just filled with nephrons, which are the functional units that actually produce the urine. So in the renal medulla, you have these things called pyramids, which have a kind of a triangular or fan-shaped structure to them. These consist of lots and lots of nephrons all crowded together, and the ducts, the collecting ducts from those nephrons, all join together down at the tip of the pyramid known as the papilla. So there's this kind of pointed tip at the tip of the pyramid known as the papilla, and that papilla then empties into what's called a calyx. calyx, calyces, calyx is singular, calyces is plural. These are the actual ducts that collect the urine from the individual renal pyramids. There are what are called minor calyces. So each papilla drains directly into a minor calyx. And I believe there's like 9 or 10 minor calyces in the kidney. And those minor calyces then join together to form larger calyces called major calyces. And I believe there are 4 major calyces. So the 9 or 10 minor calyces drain into a total of 4 major calyces. You can only see 3 major calyces in this view. There's one coming from the top, one coming from the back of the kidney, one from the bottom. What you don't see is that there's another one facing away from us, coming from the other side of the kidney. So there's a total of 4 of these major calyces. They all then join together to form what's called the renal pelvis. The renal pelvis sits right in the hilum of the kidney, right about the same point where the renal artery and vein are entering into the kidney. The renal pelvis then leads into the ureter itself, and then that ureter continues all the way down to the urinary bladder to bring urine from the kidney down to the bladder. Question?
I feel like we always see the pyramids illustrated like cut on the frontal ground.
Yep.
Are they like pyramid shaped all the way around, or just...
I think they're kind of cone shaped all the way around.
Okay.
So regardless of whether you cut them in this frontal plane or in more like kind of a sagittal plane, I think they're always going to appear triangular, but that's because it's basically a complete cone. So no matter which way you slice it.
So are there a bunch of them like in the entire kidney, or is it just like, down the middle?
Yeah, so we're seeing some here that sit kind of in the middle plane or frontal plane of the kidney, but there would be other pyramids that would be kind of coming out towards us.
Okay.
And other pyramids that would be receding away from us in 3 dimensions, all sort of converging onto the calyces. So you see that hole back there, that's a minor calyx flowing into one of the major calyces. So that would represent a pyramid that's kind of facing away from us in the back of the kidney in this view. So good question. Because you're right, they are usually just shown in this coronal or frontal section. You don't really get an appreciation for their 3D spatial relationship. I suppose Netter may have tried to do that a little bit, like with this sort of complex cutaway here. There's this sort of step off cutaway. And so you can kind of see some of the pyramids in 3 dimension, but not all that clearly. That'd be kind of an interesting illustration, would be to show just the calyces with their associated pyramids, but without any of the rest of the substance of the kidney. 3D model, there you go. Practice your Maya skills. So if you look at the renal pelvis and then how it flows down into the ureter, oftentimes you'll see the ureter illustrated a couple different ways, depending on who's actually illustrating it. You'll see here in this Netter painting that the renal pelvis is relatively large. Then right after the ureter exits the hilum of the kidney, it gets kind of narrow, and then it gets wider again. And if you look at some of Netter's other paintings where he shows the whole length of the ureter, you see that it actually varies in diameter a fair amount along its length. Turns out that's actually the accurate way to depict them. The ureter really does vary in diameter along its length. And I don't know what the functional significance of that is. Like, why should the ureter actually change diameter along its course? I mean, it's just taking urine that's just flowing from the kidney down into the urinary bladder. What's the purpose of having differences in diameter? A lot of us, and I admit to being guilty of this myself, we'll just draw the ureters as being sort of uniform in diameter all the way down to the urinary bladder. And then technically that's not really correct. So the functional structure located within both the cortex and medulla of the kidney is the nephron. I mentioned before that the nephrons are a little bit different shape in the cortex and in the medulla, but they're all basically doing the same thing. So a nephron includes a ball of capillaries known as the glomerulus, which you've probably heard about before because you've all had some physiology before, I think. There's an arteriole that is bringing blood into the glomerulus. That's called the afferent arteriole with an A, meaning going towards. And then there's another arteriole bringing blood out of the glomerulus. This is called the efferent arteriole with an E, which is referring to the fact that it's going away. And this illustration, which I did, is also inaccurate. And I guess I got to go and fix this sometime. A lot of the fluid in the blood is released by the glomerulus into the nephron. So the volume of blood leaving the glomerulus is much smaller than the volume of blood going in. So the efferent arteriole should always be significantly smaller than the afferent arteriole. So the artery going into the glomerulus should be bigger. The artery coming out should be noticeably smaller, because a lot of the fluid is actually lost into Bowman's capsule, which ultimately is what becomes the urine. Right? So don't make the same mistake that I made. And, you know, it's another one of these things that a lot of us draw it wrong. And then somebody points it out to us. And it's like, oh, yeah, that makes sense. Just didn't think of it. So the glomerulus, as I said, is just a tangle of capillaries. The capillaries are very leaky. The cells, the endothelial cells that form the lining of the capillary, or the wall of the capillary, literally have holes in them. We call it a fenestrated epithelium, meaning epithelial cells that are literally like Swiss cheese with lots of little holes in them. And fluid from these capillaries leaks out of the capillaries into this chamber that surrounds the glomerulus called Bowman's capsule. Bowman's capsule is basically just a structure that collects all of that fluid that leaks out of the capillaries. By the way, the holes, the fenestrae, the little holes in the walls of the capillary are big enough to allow fluid out. So the blood plasma, which is basically just mostly water, some of the proteins and a lot of the ions and things can come out. Cells shouldn't. So the red blood cells in that blood should not leak into Bowman's capsule, unless you had some kind of bad kidney disease, and then you can get actual blood, actual red blood cells in the filtrate. But under normal circumstances, you're just getting plasma with proteins and ions and things dissolved in it, and the cells shouldn't leak out. So that fluid, it's called filtrate, that filtered fluid that is leaking out of the capillaries and collected by Bowman's capsule, then begins this complex journey where it flows down into a proximal convoluted tubule, then down into this long skinny loop of Henle, which then starts to ascend, and then you get something called the thick ascending limb, and then another complex convoluted structure called the distal convoluted tubule, and then eventually that flows into what's called a collecting duct, and then lots and lots of collecting ducts from lots and lots of nephrons all join together and flow down towards the renal pyramid, or towards the renal papilla, to then flow into the calyx. And I'm not going to get into the physiology, because I have to teach myself every time I have to illustrate this. I have to relearn the process, but there's this very complex process by which certain ions are reabsorbed from one point, and then other ions are pumped back into the urine, and then other ions are reabsorbed. So there's this constant back and forth absorption of different ions, like especially bicarbonate ion, but also sodium chloride, and plus water itself being reabsorbed and then dumped into the nephron. The end result being that you get urine that has a certain concentration. And as I mentioned before, if you're very dehydrated, you get urine that's more concentrated because the kidney reabsorbs more of the water. Yeah, Ben?
So do we need to know like the detailed process of how it?
No.
Okay.
No, you do not need to know the details of all of those different ions that are being reabsorbed by different parts of the nephron. Just know in general that you've got this filtrate that comes out of the glomerulus, and then magic happens and you get pee. You probably all noticed some of your kidneys had a lot of cysts in them. Sometimes these result from blockages of different parts of the kidney. I don't think we saw any kidney stones yesterday or Tuesday, but sometimes a kidney stone can actually get lodged in one of the calyces and cause urine to back up in the kidney, leading to the formation of a cyst in one part of the kidney where we just have this accumulation of urine. This is an example of a kidney that has something called hydronephrosis, which usually results from a blockage of the ureter itself. And it causes urine to back up into the entire kidney. And as that urine accumulates, it just begins to press into the walls of the kidney. And slowly over time, it just obliterates, destroys the tissue of the kidney itself. And all you're left with is just this big bundle of urine-filled cysts, which of course will shut down the function of the kidney over time. This one still has a little bit of actual structure. It's still got some of the cortex, so it probably has still some functioning cortical nephrons, but still this kidney's lost most of its functionality by this point. All right, something I think you're probably going to spend more time looking at today. I don't know how much of this you got to on Tuesday, but make sure that you look at the muscles that actually make up the posterior abdominal wall. So there are 3 main muscles in the posterior abdominal wall, plus the diaphragm itself. Let me talk about these posterior abdominal muscles first, and then we'll come back and talk about the diaphragm in a little bit more detail. So there's a long, narrow muscle known as the psoas, and it has 2 parts. The larger part is psoas major, and then there's a much smaller little skinny part with its own separate tendon, usually sits right on the anterior surface of the psoas major. That's called psoas minor. And not everybody has a psoas minor. It's one of these things that's variable in the population. So you may have just a psoas major and you may not have a psoas minor at all, or it may not be very obvious. The psoas major has its origin from the transverse processes of all of the lumbar vertebrae. And if you follow it down, it actually crosses over the pubic bone, over the front of the pelvis, continues down into the upper part of the thigh, where it inserts on part of the femur. And turns out this is one of the primary flexor muscles of the hip. So this is one of the main muscles that brings the thigh forward at the hip joint, which would be flexion of the hip, or we could say flexion of the thigh at the hip, or you could say flexion of the femur at the hip joint. Either way, they all mean pretty much the same thing. Another muscle that is just a little bit lateral and a little bit deep to the psoas is the iliacus muscle. And this muscle originates from the inner surface of the ilium all the way around that sort of bowl-shaped structure of the ilium. And then if you follow the iliacus distally, it also crosses over the front of the pubic bone and continues down to insert on part of the femur. The iliacus and the psoas tendons actually join together to form something called the iliopsoas tendon, which is what is inserting on the femur. And in case anybody's interested, you don't have to know this for this exam, but they're inserting on something called the lesser trochanter of the femur. Yeah, you will need to know that for the final exam because that's part of the hip and lower limb. Iliacus also helps to flex the thigh at the hip joint. All right, so iliacus and psoas together are both pulling the femur forward, which would be flexion of the hip joint. And both of them are innervated by a nerve that you'll see today in lab called the femoral nerve. That femoral nerve is also going to be the major nerve to the anterior thigh. It innervates all the quadriceps muscles in the front of the thigh. But before it does that, it innervates psoas and iliacus muscles here in the pelvis. Your question? No. Just stretching. Okay. No problem. By the way, a little bit of trivia about psoas major. Anybody eat pork tenderloin? No? Anybody know what a pork tenderloin is? Long, skinny Little piece of pork comes in a little, usually comes like in a little plastic package. That's a psoas. That's a pig psoas. Anybody like filet mignon? The steak, yeah. Cow psoas. So you can actually buy an entire beef tenderloin, which is the entire psoas major muscle.
Reason anatomically why it's like a prized cut of meat.
I don't know. I don't know. I mean, pork tenderloins are incredibly tender. Beef tenderloin, which is what you slice a beef tenderloin into little pieces, and that's filet mignon. And very, very super tender, but also very lean. But I don't know why that particular muscle in both cows and pigs is very lean and very tender like that.
That's why I said small. You're talking to like a group. I think that like 60% of us in here are vegetarians.
Yeah.
I think you're right. I think there's like 60 or 70% of us.
Yeah. And then also anybody who's kosher can't eat anything from the rear quarter of an animal. So you can't have pork tenderloin or beef tenderloin. I'm not sure that all kosher people know that. I found that out when I went to a Jewish butcher one time and tried to get filet mignon, and they said, no,
We
don't do that. It's like, oh, okay. At that time, before I was teaching anatomy, I didn't realize that it was a psoas muscle, that it came from the rear quarters. I don't know if that applies to halal also or not. I have no idea how similar those eating rules are. All right, so the other muscle of the posterior abdominal wall is called the quadratus lumborum muscle. And this muscle is originating from the iliac crest and then inserts on transverse processes as well as ribs of some of the lower vertebrae and lower ribs. And this muscle plays a small role in being able to bend sideways. So that muscle is going to contract and to pull the torso either to the left or to the right. And also a very small role in being able to extend the vertebral column. I mean, most of this motion of extending the vertebral column is being controlled by the erector spinae, but those quadratus lumborum muscles in the back can also assist with this ability to extend the back like that.
Could you repeat that origin?
Yeah, origin is iliac crest. And the insertion is just transverse processes and ribs of the, I forget exactly which levels. So if I don't remember, you guys don't have to either.
Any leg helps you bend to the side.
Yeah, I mean, that's probably its main job is being able to bend one way or the other. Yeah.
I just have a question. I can't remember, but I think I was just reading my notes today, and we didn't need to know origins and insertions for the abdominal one. This is
That's
posterior. I apologize.
yeah, at least psoas and iliacus. I mean, but they're pretty simple.
Okay.
So the diaphragm itself is a muscle, a very, very complex muscle. And you definitely don't need to know the whole origin or insertion of this. It's quite complex. Suffice to say that it's originating from a bunch of the ribs, a bunch of the costal cartilages, the sternum, different parts of the lumbar vertebrae, pretty much everything all the way around the abdomen, pretty much every bone near the upper part of the abdomen. So the lumbar vertebrae, ribs, costal cartilages, sternum, etc., are giving rise to the diaphragm. We will look at some specific parts of it in just a minute. I think in this picture, you can also tell, actually, the insertion of diaphragm is relatively easy because the entire thing basically inserts into itself. All of the different parts of the diaphragm converge on something called the central tendon. You can see that big sort of gray area there where all the fibers of the different parts of the diaphragm are all converging on that central tendon. So if you were to stand down by the cadaver's feet and look up towards the diaphragm, assuming we hadn't cut all the ribs and pretty much destroyed a lot of the diaphragm, it would look something like this. And again, you can see how it's originating all around the inside of the various bones of the thorax and abdomen. So sternum anteriorly, ribs and costal cartilages laterally, lumbar vertebrae, the vertebral bodies, as well as the transverse processes of some of the lumbar vertebrae, all giving rise. And then you see how all the fibers are converging towards that central tendon. Couple of structures that I do want you to be familiar with. You'll be looking for them in lab, and they are listed on your required structures list. There are two structures called crura. The singular is crus, which literally means leg in Latin. Plural would be crura. And these are two bands of muscle that are originating from the lumbar vertebrae and actually help to form the hiatus for the esophagus as well as the hiatus for the aorta. So there's a left crus, which is going to lie on the left side of the body, just to the left of the aorta, as it passes from the thorax into the abdomen. And then there's a right crus that lies on the right side of the aorta. The right crus actually extends up towards the central tendon, but then kind of does a U-turn and loops around on itself to form the entire esophageal hiatus. So the esophageal hiatus, where the esophagus pokes through, is formed entirely by this right crus kind of looping around on itself. Anybody ever hear of something called a hiatal hernia? Is that a completely foreign word to all of you? Okay. So I think I've mentioned this before, that a hernia just means something poking through where it doesn't belong. Usually we think of inguinal hernias when people say the word hernia. Maybe you might think of umbilical hernia around the umbilicus, but there are lots and lots of kind of hernias throughout the body where something just pushes through a space where it doesn't belong. And so a hiatal hernia is when part of the stomach actually slides up through the esophageal hiatus into the thorax. And there are two different ways that can happen. Literally, part of the cardia of the stomach, which is where the esophagus drains into the stomach, can simply slide up through the opening so that part of the stomach comes to lie, superior to the hiatus. Another way that it can happen is that the fundus of the stomach can actually poke through the esophageal hiatus next to the esophagus, and part of the fundus can kind of work its way up into the thorax. I understand. I've never had one myself, but I understand that they are kind of painful. A lot of people can confuse the symptoms of hiatal hernia with heart attack because they get sharp pain right here in this part of the chest. They can be, besides just the fact that they're painful, they can also be dangerous long-term because the esophageal hiatus helps to prevent stomach acid from actually going up into the esophagus. But if part of your stomach actually sits up above the esophageal hiatus, you lose that sphincter, preventing acid from going up into the esophagus. So then you get a lot of gastroesophageal reflux, and you end up with reflux disease, which can then lead to something called Barrett esophagus, which is a cellular change in the esophagus due to the stomach acid. And then Barrett esophagus is a precursor to esophageal cancer. So just acid reflux can ultimately lead to esophageal cancer if it's untreated. So hiatal hernia is referring to a hernia through the hiatus, through the esophageal hiatus, hernia of part of the stomach sliding up from the abdomen up into the thorax. All right, so we've got these two crura, left crura, which is just to the left of the aorta, or excuse me, left crus, just to the left of the aorta, right crus, which goes to the right of the aorta, but also forms this loop that forms the esophageal hiatus. The other things to look for in lab today, and your dissector will mention these, although I think the dissector does a lousy job of describing them, and so it's helpful to see them here on this picture. There are things called arcuate ligaments. There's a medial arcuate ligament and a lateral arcuate ligament. These are little ligamentous structures that form like a little arch or a little bridge over the psoas major. That would be the medial arcuate ligament. And then laterally, there's a lateral arcuate ligament that forms a little arch or a little bridge over the quadratus lumborum. If you look on the right side of the slide, which is the left side of the patient, you can actually see how these arcuate ligaments are formed. There's a ligament that extends from the lumbar vertebral bodies out to the tip of the transverse process of L1. And that's the medial arcuate ligament, which crosses over the upper end of the psoas major. And then there's another ligament that continues from the tip of that transverse process out to one of the ribs, out to the tip of the 12th rib. So that's forming the lateral arcuate ligament. So a couple of things that have relationships to the muscles of the posterior abdominal wall. Over the quadratus lumborum, yeah. Medial is over the psoas, lateral is over quadratus lumborum. Did I say that wrong?
No, you said it right.
Okay, thank you. All right, last thing that you will be looking for today in lab are the nerves of the posterior abdominal wall. These make up what's called the lumbar plexus. We probably won't actually see the sacral plexus where you get way down into the sacrum, but you'll definitely see these branches of the lumbar plexus, or at least hopefully you'll see these branches of lumbar plexus. When I try to identify these nerves, I always have to try to find them in order. I try to find the most superior one because it's relatively easy to recognize and identify. It has some landmarks that help you identify the first one. And then I work my way down from there, trying to identify them in order. The tricky part with identifying these nerves is that sometimes you don't have them all. So it then becomes difficult to name them in order if you're missing one. But I'll tell you what to look for and describe them in order, assuming that you actually have the textbook pattern in your cadaver. So the one that I always start looking at first, and this would include if I was looking on an exam, I'd look for an important landmark to identify this first nerve. It's called the subcostal nerve. It's the ventral ramus of T12. So hopefully you remember from the thorax that the ventral rami of the thoracic nerves became the intercostal nerves, right? So ventral ramus of, say, T10 is the same thing as the 10th intercostal nerve. This is the ventral ramus of T12, so it's the ventral ramus of one of the thoracic nerves. We don't call it an intercostal nerve because intercostal means between the ribs. And this is sitting below the 12th rib, so it's not really between any ribs. It's below all of the ribs, hence the name subcostal, below the ribs. So this would actually be sitting in the costal groove. Remember, that's the little groove on the inferior edge of the rib. Be sitting in the costal groove on the inferior edge of the 12th rib. So if you can find the 12th rib, and then you may have to dig for it a little bit, but running right along the inferior border of that 12th rib should be this subcostal nerve, the ventral ramus of T12.
Below the diaphragm.
This is below the diaphragm. Yeah. The 12th rib forms part of the origin for diaphragm. The diaphragm doesn't continue below the 12th rib at all. So this nerve is completely below the diaphragm. So then we come to two branches that are coming from the ventral ramus of L1. So the ventral ramus of the first lumbar vertebra, the L1 ventral ramus, is going to split into two separate nerves. The more superior one, the more superior branch of L1 is called the iliohypogastric nerve. This is going to pass into the abdominal wall musculature, so it's going to go into all of those oblique muscles and wrap around towards the front of the body. It's kind of in the groin area on the anterior abdominal wall. And then the lower branch of L1 is genitofemoral nerve, which you ilioinguinal nerve. What am I saying? Ilioinguinal nerve, which you may have already seen in the body before. That's the one that's running through the inguinal canal, right alongside either the round ligament or the spermatic cord. But right off the bat, this is one of the places where identifying these things can be tricky. If you look at the way Netter's illustrated it here, you can see that iliohypogastric and ilioinguinal are already separate. It's as soon as you can see them, like you can't see where they're joined together as a single ventral ramus of L1. Some cadavers, if you're really lucky, you'll actually see L1 kind of lying between the psoas and the quadratus lumborum muscles, and then you'll actually see L1 split into these two nerves. So it looks kind of like a Y, where L1 splits into iliohypogastric and ilioinguinal. Other times it's going to look a little bit more like what you see here, where the iliohypogastric and ilioinguinal are already split as soon as you see them. The tricky part is that sometimes all you see is L1 and you never see them split. So there's just one nerve and you never see a separate iliohypogastric and ilioinguinal. What probably happens is that the nerve is going to pass into the oblique muscles on the side of the abdominal wall and split later, but at a point where you can't see it. So that becomes trickier when you're trying to count down from top to bottom. You've only got one nerve there. You just have to kind of go by some of the other landmarks to try to figure out, okay, do we have just one L1 nerve or do we have a separate iliohypogastric and ilioinguinal? I'm going to skip over genitofemoral for a second. We're going to continue down along the abdominal wall, the posterior abdominal wall. There's a nerve called the lateral femoral cutaneous nerve. This is actually derived from two ventral rami, from both L2 and L3. So this would be the next nerve that would be sitting just inferior to the branches of L1. This one actually has a fairly diagnostic relationship anatomically. It's going to be heading directly towards the anterior superior iliac spine on the ilium and in the pelvis. So if you find a nerve that's kind of emerging from behind the psoas and it looks like it's heading straight towards that ASIS, there's a good chance that's lateral femoral cutaneous nerve. I forget if your book uses the modern anglicized version of that, lateral cutaneous nerve of the thigh. That would be the same thing as lateral femoral cutaneous nerve. All right, so now let's jump back to this thing called the genitofemoral nerve, which is another branch of L2. This one's usually pretty easy to identify, at least if you have the textbook pattern. Usually genitofemoral nerve is actually going to emerge from the anterior surface of the psoas major muscle. So if you look over on the left side of the slide here, you'll see that genitofemoral nerve is piercing through the psoas major and then runs right down along the anterior surface of psoas major. So that's usually pretty diagnostic. You see a nerve that's piercing through psoas major and runs right down along the front of psoas major. That's genitofemoral. Now, eventually, that's also going to split. So sometimes we see multiple branches of genitofemoral. It's going to split into a genital branch, which is a sensory nerve to some of the external genitalia, like the scrotum in the male or the labia major in the female. And then there's a femoral branch that's sensory to the inner surface of the thigh. All right, continuing a little bit more inferiorly. By far, the biggest nerve you're going to see in this area is the femoral nerve. That's the one that innervates the psoas, the iliacus, and then it's going to continue down into the thigh to innervate all the quadriceps muscles in the thigh. The only thing that's the least bit tricky about finding the femoral nerve is that it's frequently hidden by the psoas major. What you need to do is just use your finger and just bluntly dissect along the lateral border of the psoas major and kind of lift up the psoas major a little bit. and you'll see this great big nerve sitting just posterior to the edge of the psoas major muscle. That's femoral nerve. And that's actually derived from branches of L2, L3, and L4. Just medial to the psoas major muscle is another nerve also derived from L2, 3, and 4 called the obturator nerve. Another one that people seem to misspell a lot or mispronounce. People want to call it the operator nerve. It's obturator nerve. That can be kind of tricky to find initially, just because the area medial to the psoas often has a lot of fat in it, like fat that's extending down into the pelvic cavity, as well as just some loose connective tissue. So you probably have to do some blunt dissection just medial to the psoas major muscle, and then you may find this nerve within that fat and that connective tissue just medial to the psoas. Interesting thing about this nerve is usually when we see it, it seems very, very tight, like it's been pulled taut for some reason. And sometimes I have the best luck trying to find this nerve by simply reaching into that fatty connective tissue medial to the psoas and just kind of feeling around, and then you can kind of pluck this thing like a guitar string. It's just this tight nerve, and then it's like, oh, okay, there it is. You can actually feel it before you see it, and then you go in and just clean the fat off of it to actually be able to visualize it. The rest of this we won't see until we get into the pelvic cavity. So there are some great big nerves. These are actually the ventral rami of the sacral spinal nerves down here, but you won't see those today. You'll see those when we get into the pelvic cavity. I believe the dissector will actually have you try to look for the sympathetic trunk. Can be a little tricky to find because it looks obvious, like, oh, there's a sympathetic trunk right there. You see these chains of ganglia. But in this Netter painting, he's removed the aorta and the inferior vena cava, and we don't want to do that. We're not going to remove those vessels. So the sympathetic trunks can actually be a little challenging to find because they're kind of hidden behind the aorta and the inferior vena cava. But if you lift up on those vessels, you might actually be able to spot the sympathetic trunks continuing, and they continue all the way down into the sacrum, and eventually all the way down even to the coccygeal level, way down by the tailbone. Oh, I forgot I put this label in here, something called the lumbosacral trunk, which is the ventral rami of L4 and 5. I don't know that you're going to see that today, but that's another one that we'll definitely see when we study the pelvic cavity after this next exam. Okay, so I think that does it. Like I said, a little bit early today, so I'll see you all on Monday for the exam, usual format.